To understand congenital heart defects, we must start with the baseline plumbing. This schematic tracks normal fetal circulation. Well-oxygenated blood travels from the placenta through the umbilical vein, bypassing the liver via the ductus venosus to enter the right atrium. From the right atrium, the majority of this highly oxygenated blood shunts across the patent foramen ovale into the left atrium. This prioritizes the highest oxygen concentrations for delivery to the brain. Meanwhile, returning deoxygenated blood from the superior vena cava enters the right atrium, drops into the right ventricle, and bypasses the uninflated lungs by crossing the patent ductus arteriosus, or PDA, to reach the lower body. At birth, the first breath acts as a mechanical switch. Lung expansion massively increases arterial oxygen tension and plummets pulmonary vascular resistance. That deoxygenated flow instantly diverts away from the PDA and floods the newly opened pulmonary circuit. Because blood is now pouring into the pulmonary veins, pressure in the left heart rapidly eclipses pressure in the right heart. That pressure inversion physically slams the flap of the foramen ovale shut. Normal postnatal survival relies entirely on this abrupt, permanent shift in vascular resistance, a balance broken by congenital architectural errors. Beyond the macroscopic plumbing, neonatal cardiac cells operate under severe mechanical limits. Compared to an adult, the neonatal heart has 50% fewer myofibrils, and the ones present are disorganized and immature. This lack of density severely restricts ventricular compliance. The infant heart is physically rigid. It cannot stretch to accommodate large, sudden increases in volume. Looking at the standard clinical equation for cardiac output, heart rate multiplied by stroke volume, that rigidity means a neonate stroke volume is essentially fixed. The heart cannot pump harder or deeper. It can only pump faster. This creates the hypoxia-bradycardia spiral. If a neonate becomes hypoxic, their reflex is to drop their heart rate. Because stroke volume cannot compensate, that bradycardia instantly crashes their total cardiac output. The drop in cardiac output slashes systemic oxygen delivery, which accelerates the tissue hypoxia and drives the heart rate even lower. Complicating this, the neonatal sarcoplasmic reticulum is small and inefficient. It cannot store internal calcium effectively, leaving the heart heavily dependent on plasma ionized calcium to maintain its baseline contractility. If a pediatric patient's heart rate drops on the monitor, you must treat it as a hypoxic airway emergency first. The heart is reacting to an oxygen deficit, not a primary cardiac event. For any patient with an abnormal intracardiac connection, blood flow obeys the path of least resistance. This ratio between systemic vascular resistance and pulmonary vascular resistance is the master governor of shunt direction and perioperative management. Left-to-right shunts occur when SVR outweighs PVR. High-pressure blood from the left side of the heart is forced backward across the defect, inappropriately flooding the pulmonary circuit. Chronic exposure to this high-pressure flow causes the pulmonary arteries to undergo smooth muscle hypertrophy. Over time, this thickens the vessels, actively increases pulmonary vascular resistance, and induces congestive heart failure. Ventricular septal defects are the most common congenital anomaly. Because the defect sits between the heavy pumping chambers, the volume of blood pushed through the gap is dictated by the continuous wrestling match between SVR and PVR. The strict anesthetic goal for a VSD is to maintain SVR higher than PVR. Dropping systemic resistance will reverse the flow, sending unoxygenated blood directly into the aorta. With an atrial septal defect, the shunt flows from the left atrium to the right atrium, simply because the thick, muscular left ventricle is naturally less compliant than the right ventricle, making the right side the path of lower resistance. Clinically, an ASD often presents with a pronounced, fixed split S2 murmur and a right bundle branch block on the EKG due to the right-sided volume overload. Atrioventricular canal defects combine atrial and ventricular septal gaps. Highly associated with trisomy 21, these lesions often involve abnormal placement of the conduction system. This EKG strip demonstrates the vulnerability. Prolonged PR intervals and distinct first-degree AV blocks are common. Left-to-right shunts create a mechanical volume overload that slowly and persistently destroys the pulmonary vasculature. A patent ductus arteriosus is a persistent connection between the aorta and the pulmonary artery. Before attempting surgery, clinicians often use prostaglandin inhibitors, like indomethacin or ibuprofen, to chemically force the vessel to close. If medical closure fails, surgical ligation is required. Surgeons access the chest wall, isolate the PDA, and physically crimp the vessel with a titanium clip. This arterial line waveform shows the immediate hallmark of a successful ligation. Because systemic blood is no longer constantly leaking into the pulmonary artery, the diastolic blood pressure abruptly and permanently shifts upward. The endpoint of uncorrected left-to-right shunting is Eisenmenger syndrome. Years of relentless volume overload causes irreversible pulmonary hypertension. The pulmonary vascular resistance climbs until it permanently outweighs systemic resistance. The pressure gradient flips and the flow arrow reverses. Deoxygenated blood is now forced out of the right heart and into systemic circulation. The patient develops late-onset cyanosis, and the defect is completely inoperable. Right-to-left shunts are cyanotic lesions. Structural blockages force deoxygenated blood away from the lungs and straight into the systemic circuit, resulting in profound hypoxemia. Tetralogy of Fallot features 4 concurrent traits, entirely driven by the first, pulmonary stenosis. This severe narrowing of the right ventricular outflow tract acts as a physical roadblock to the lungs. Because blood cannot push past the stenosis, pressure builds, thickening the right ventricular wall. The blood escapes through ventricular septal defect, pushing straight up into an overriding aorta that sits directly above the septal gap, absorbing the unoxygenated flow. If the pulmonary obstruction suddenly tightens, often due to crying or agitation, the patient experiences a TET spell, where nearly all pulmonary blood flow stops. Treating a TET spell requires manipulating both sides of the resistance seesaw simultaneously. You must increase systemic resistance using ketamine or phenylephrine, or tucking knees to chest, while dropping pulmonary resistance by hyperventilating with 100% oxygen. In transposition of the great arteries, the plumbing is completely backward. The aorta is attached to the right ventricle, and the pulmonary artery is attached to the left ventricle, creating 2 closed independent loops. A patient with this anatomy cannot survive without a deliberate mixing lesion. Clinicians must run continuous prostaglandin E1 infusions to forcibly keep the PDA open, allowing the 2 circuits to share oxygen until surgical correction. Severe obstructive lesions, like critical aortic stenosis, also require this protocol. The left heart cannot pump to the body, making systemic circulation entirely PDA dependent. Managing cyanotic defects requires artificially boosting systemic resistance to force blood past obstructions, or chemically maintaining fetal pathways to guarantee the brain receives trace amounts of oxygen. Chronic hypoxemia forces the pediatric body to overproduce red blood cells to maximize oxygen carrying capacity, resulting in severe polycythemia. If the hematocrit crosses 60%, the blood becomes dangerously viscous. This sludging heavily restricts flow through the capillaries, posing a massive risk for stroke. To prevent perioperative strokes, these patients require mandatory isovolemic hemodilution before you can safely induce anesthesia. Intracardiac shunts alter the pharmacokinetics of anesthetic induction. This matrix tracks how physical blood flow paths dictate the speed of drug delivery to the brain. With a right-to-left shunt, IV inductions are abnormally fast. The drug bypasses the pulmonary circuit and is injected directly into the systemic arterial flow, hitting the brain in seconds. Conversely, with a left-to-right shunt, IV drugs are delayed because they get diluted in the flooded pulmonary circuit. Annihilational agents, however, remain on a normal timeline or work slightly faster due to the increased pulmonary blood flow. Standard dosing timelines do not apply here. The physical plumbing of the defect dictates exactly when your drugs will take effect. Ketamine is the gold standard induction agent for right-to-left shunts or any critical flow obstruction. It preserves or actively increases systemic vascular resistance, keeping the pressure gradient firmly on the systemic side. For maintenance, sevoflurane and isoflurane are highly effective. They preserve cardiac output without severely depressing contractility. Midazolam combined with fentanyl is dangerous in this population. The combination depresses cardiac output specifically by dropping the heart rate. With a fixed neonatal stroke volume, that bradycardia is disastrous. Once the patient is intubated, the ventilator becomes your primary tool for manipulating resistance. On this monitor interface, applying PEEP to compress the lung tissue or adding nitrous oxide will actively drive pulmonary vascular resistance up. To drive pulmonary vascular resistance down, you increase the FiO2 to maximum, deliver inhaled nitric oxide, and hyperventilate the patient to induce alkalosis. Intravenous fluids must be tightly controlled to prevent right heart volume overload, but they remain a necessary tool if right ventricular dimpling or low CVP is observed. Everything returns to the cellular baseline. A loose airway guarantees hypoxia. Hypoxia guarantees bradycardia, and bradycardia destroys cardiac output. Mastering pediatric cardiac anesthesia means identifying the anatomical lesion before you push a single drug, and using your anesthetics and ventilator to actively pilot the SVR-PVR seesaw.